Am I audible?
Yes, sir.
Yes, sir.
Yes, sir. Good evening, respected session, sir. Today's session, sir.
Yeah.
Thank you, sir. Good evening, respected professors. I welcome you all to today's session on anesthetic aging. The basic subjects very relevant to all budding anesthesiologists. Over to professor and students.
Right. So today we have a discussion on uptake and distribution and elimination of inhaled anesthetics. The message given in the link is just mentioned inhaled anesthetics, but since you people wanted topic discussion on intake and distribution and elimination of inhaled anesthetics, we'll try to discuss that. It's not going to be a didactic one-way lecture. It is going to be an interactive session because I have formulated some questions to ask. But before we go on to the topic as such, I would like to ask something about the basic respiratory physiology. Okay? So we have already covered respiratory physiology and cardiovascular physiology. So all of you must be knowing by this time how we are taking in the oxygen and eliminating the carbon dioxide, which is the primary function of respiratory system. So can you tell me, Muthupriya, how we are able to take the oxygen into our body for the usage by cells for their oxidative phosphorylation and the resultant carbon dioxide produced by that metabolism, how we are eliminating?
Through oxygen cascade, there is a stepwise degradation of the partial pressure of oxygen, and it is getting delivered to the tissues, sir.
How is it first of all taken from the atmosphere? See, we always should start from the inspired concentration, isn't it?
Yes.
We get the oxygen from the atmospheric air surrounding the ambience. So how does that air get into our body?
We breathe in.
I think it need not be Muthupriya. It can be anyone who wants to answer. We can answer. I don't want to target Muthupriya and bother with these questions. Any of you who can answer that question. Can be Soundarya, it can be Abhirami, can be Kalpana, Sri, Vijayalakshmi, Bindu, Ranjini. Whoever knows the answer, you can come out with the answer. Okay, let me give you a clue. Your inspiration and expiration, are they important for your transfer of gases from the atmosphere into the body?
Through negative intrathoracic pressure, air is inspired in.
Inspiration. First you start with the act of inspiration, isn't it? Your muscles of respiration, especially the diaphragm, they during inspiratory phase, they create a negative pressure which sucks the air from the atmosphere into our respiratory tract through our nose and mouth, goes into the trachea, goes into the bronchi, the lobar bronchi, right and left, then going to the segmental bronchi, and ultimately it has to reach the alveoli. So what is the pressure of oxygen in the atmospheric air?
760 millimeters.
760 millimeters is the barometric pressure, atmospheric pressure. Is everything oxygen there? What is the percentage of oxygen?
21%.
21%. So 1/5 of the pressure is the pressure exerted by the oxygen, isn't it? Roughly it will be about 150 or 157 to be exact. So 1/5 of the content of the atmospheric air is oxygen, and that 1/5 air occupies or produces a pressure of 1/5 of the total atmospheric pressure. And at a 150 pressure, when it enters our respiratory tract through our nose and your upper respiratory passages, when it reaches the alveoli, does it remain that same 150 or it is getting slightly reduced?
Reduced.
It gets reduced. Okay, so it gets reduced to say some 110 or 160,
100.
100 or 104, 110 like that. Okay?
Yes.
But what is the pressure in the venous blood that is coming to the pulmonary alveoli? What
97,
is the
sir.
pressure of oxygen in the venous blood that is coming to the pulmonary capillaries? It's very low, isn't it?
Yes, sir.
It is not like your arterial oxygen. It is desaturated, or oxygen has been extracted at the tissue level, and the venous blood is a deoxygenated blood which has a lesser oxygen content, roughly say 60 to 75%. So because of that lesser pressure gradient and the alveolar pressure of oxygen being higher, it is able to pass through the alveolar capillary membrane and then go into the blood and then get itself attached to the hemoglobin which is there and become oxygenated blood, and it is being carried through the pulmonary arteries to the left side of the heart to be pumped into through the left ventricle to the parts of the body. Agreed?
Yes, sir.
Yes. So once the left ventricle pumps this arterial blood, which has a content of almost 100 millimeters of mercury, or 90 to 95 to 100 millimeters of mercury, does it reach at the same pressure at the tissue level? Is the pressure, partial pressure of oxygen, the main aorta and in the capillary at the tissue level, will it be the same or will it be different?
Different, sir.
Different. So as it goes down, the pressure goes slightly drop. And what is the ultimate pressure it reaches when it goes to the capillary level to subserve the tissues, the cells rather?
5 to 7 millimeters.
5 to 7 millimeters of mercury. Okay. And if it goes to less than 2, it is called pasture point.
Pasture point.
Okay. So that is how the whole thing goes to the cells. So the inhaled anesthetics, how are they delivered to the body? When you want to anesthetize a patient with an inhalational agent, how do you administer this drug?
The partial pressure of the lung is equal to the partial pressure of the brain.
We are administering to the respiratory tract. That is the basic answer. Okay, I don't want you to talk about high flown physics and all at this stage. I am just wanting to start it from a very, very layman's term and then build it up on to use the correct terminology that is required as a anesthesia PG. You have to answer in the examination. So the inhaled anesthetics are delivered to the patient through your respiratory tract. As simple as that, isn't it? So the same way how oxygen has a higher pressure in the atmospheric air and at the alveolar level, and there is a lower pressure in the blood, because of the pressure gradient, it is able to cross over and go to the body. The same way the inhalational agents, you have to deliver at a particular higher partial pressure. And does our blood contain any inhaled anesthetics in your normal life? No, we don't have, isn't it? When the patient comes for anesthesia and surgery, he doesn't have any inhaled anesthetics in his body. So we are delivering the inhaled anesthetics from the exterior and make him breathe or inhale that agent. We make him inspire that agent. Okay. So you have to deliver it at a particular partial pressure. This is the particular terminology you should be very, very clear about, so that the concentration is of course important, but the partial pressure of the inhaled anesthetic agent is the term which is going to be used throughout the uptake and distribution of your anesthetic agents, right? So that partial pressure, at a pressure we have to deliver the gases or the vapors to the respiratory tract of the patient, and he will inhale or inspire that through his respiratory tract, and that will reach the alveoli. So there will be two pressures here now. One is the inspired pressure of the inhaled agent, which is delivered by the machine or the anesthetic equipment that you are using. There are so many other gadgets which we can use to deliver that, not only your anesthesia machine, but olden days they were using even open method of open drop. All that is the method of making the patient inspire the volatile anesthetic agent. Okay. So once you deliver that, it is to be called as inspired inhalational agent partial pressure, which can be symbolically written as FI. Okay, inspired concentration or inspired partial pressure. That has to reach the alveoli, and once it gets the alveoli, when it becomes equal, the partial pressure of the inspired gases and the partial pressure of the alveoli, will there be any further flow? The alveolar partial pressure of the inhaled anesthetic agent and the inspired partial pressure, if they become equal, will he be able to absorb or take more inhalational agents?
No, sir.
No, they become equilibrium. Since they have gone into equilibrium. Unless the gradient is present, it cannot travel. So how does further gases go into the alveoli?
Solubility of the gas.
The gas passes from the alveoli into the blood.
Yes.
Okay. So there is an uptake of the gases from the alveoli into the blood because of the solubility factor of the gas or the vapor that you are delivering. Each gas has got a different potency or a power to get dissolved in the blood that is coming to the capillary circulation. So once that vapor or gas is taken up by the blood, there is a drop in the pressure. So further gases can come from the inspired or delivery from the machine and fill up the alveoli in that space, and then this transmission goes on. So the first uptake occurs at the alveolar blood level, and that is dependent, that uptake is dependent on what is called the blood gas solubility or blood gas partial coefficient. What does that blood gas partial coefficient mean? This terminology also you have to understand very clearly to make sure that you have a clear concept about the inhaled anesthetic physiology. So why do different inhaled anesthetics have different types of solubility?
To make them potent and clearance.
Potent for back.
Right, I think without the utilities you are not able to answer questions, or I am not clear to make you understand what I want to convey. Is my question clear, or you are not able to understand the questions? Okay.
Yes.
Now all of you would have read about the, did you all read about the uptake and distribution before
Yes, sir.
coming to the class?
Yes, sir.
Some of you have already finished DA, must be knowing about that. So I will give you an example. Nitrous oxide, what is the blood gas solubility coefficient? What is the value for that?
Very low, 0.4.
Low, sir.
It's
0.4.
very low, but what is
0.4.
the value? 0.42,
4, sir.
isn't it?
Yes, sir.
Desflurane is 0.47. And just 1 second. Hello? I'm taking a class, Papa. What do you want? You have cyclopam, you take one cyclopam and dilute. You have taken those treatments, last time. Same like that. Same like take it. So whereas what is the solubility coefficient of sevoflurane or your isoflurane?
0.6, sir, for sevoflurane.
0.6.
Sevoflurane.
Sevoflurane. It's so low.
1.4 for isoflurane, sir.
So why these differences are there? What do you mean? If the number is very high, what does it mean? If the number is low, what does it mean?
If it is low, it is low.
It is
This
easily
less
soluble and
Less lipid
insoluble,
soluble.
sir.
Insoluble, less soluble. You cannot
Less
say
Less
insoluble.
lipid soluble.
Insoluble means it is not at all mixing with the blood at all. Okay.
Yes,
So
yes,
it is less soluble and more soluble. So where the number of blood gas coefficient, if the number is more, it is more soluble. If the number is less, it is less soluble. So what is the advantage of an agent which is less soluble and an advantage of an agent which is more soluble?
easy induction and easy recovery.
When it is less soluble, it is not totally mixing with the blood. It is just getting into the blood, just carried by the blood, and it will be delivered much faster. Whereas a drug which has a higher blood gas solubility coefficient number will dissolve more intensely with that, and it will take longer time to fill up and achieve the partial pressure required for its effect. And it will also take longer time to get rid of the drug from your blood, and really, the recovery also will be much delayed. That is the main point that you have to understand. Okay? And once it is taken up by the blood, where does it go? Where is it delivered? It is taken up from the pulmonary capillary circulation. So after taken up by the pulmonary circulation blood, where does it go? These inhaled anesthetics which are
Which blood supply area like brain and heart, sir?
it is going to be delivered to various tissues. And how these tissues are classified?
Vessel rich group and fat, muscle and
vessel poor group. Some books say 4 categories: vessel rich group, muscle, fat, and vessel poor group. Some books say only 3 categories: vessel rich group, muscle, and fat. So which are all the organs which have a high blood supply in our body?
heart, brain.
Brain. First and foremost is brain, then there is heart, then there is kidney, then there is liver. Okay. These are the 4 organs which have the maximum or richest blood supply. So they are called vessel rich group blood. Out of this, where can this inhaled anesthetic act? Can it act on the liver? Can it act on the kidney? Can it act on the heart? Or can it act on the brain?
Brain, sir.
It has to act on the brain, which is the central nervous system. Okay. So once the brain tissue is avidly taking this inhaled anesthetic agent, the blood has to deliver that agent to the brain. So what is the solubility coefficient there? Again, it has got to get dissolved. This is the tissue blood equilibrium or coefficient. So there are 2 solubility levels. One is at the pulmonary level, which is called the blood gas, because the gas is on the alveolar side. It has to come into the blood. It is called blood gas solubility coefficient or partition coefficient. Once the inhaled anesthetic is achieved the desired partial pressure from the alveoli, it is taken up and then delivered to the main site of action, the brain, where it has to be delivered from the blood to the brain, which is called the tissue blood partition coefficient. So these 2 transfers have to take place properly for you to achieve a particular level of anesthesia or induction or maintenance of anesthesia. So the partial pressure of the inhaled anesthetic agent from the machine or the delivery system, which is inspired, should become equal to the partial pressure of the inhaled anesthetic agent in the alveoli, which should slowly fill up the blood circulation and get delivered to the brain. And the partial pressure of brain, when it achieves the same value as in the alveoli, you will get a steady state of anesthesia induction and maintenance, and no more anesthetic can be taken up by these tissues. So the ultimate aim of your inhaled anesthetic is to achieve an equilibrium between the inspired partial pressure to alveolar partial pressure to the brain partial pressure. If you achieve these three to be equal, then you would have induced the patient to the desired level of anesthesia. So this is what is called the uptake. And what are all the factors that are going to affect or the have effect on the transfer or the uptake of these gases and vapors, that we will see now. So I will share my screen and we'll have a better idea about what we have to learn. Hope this is clear. So what is the basic concept of inhaled anesthetic? What are the three phases of inhaled anesthetic physiology?
Uptake, distribution, and metabolism.
And elimination. Very good. So there are three phases: uptake, distribution, and elimination. Fantastic. So the primary object is to attain a constant optimal brain partial pressure of the agent. This is the primary objective of our inhalation anesthesia. So the brain and other tissues equilibrate with the partial pressure of inhaled agent delivered to them by arterial blood supply. And arterial blood supply has to equilibrate with the alveolar partial pressure. And the alveolar partial pressure of inhalation agent mirrors the brain partial pressure in a steady state. So once you achieve the equilibrium here between the alveolar pressure and the brain pressure, patient will be in an anesthetized state. Until then, he will not be fully anesthetized. So the inspired partial pressure should become equal to alveolar partial pressure, which should become equal to arterial partial pressure, which should become equal to brain partial pressure. This is what we want to achieve when we use inhalational agents for inducing and maintaining anesthesia in any patient. If this basic principle is understood, then you can do a lot of jugglery with the manipulation of inspired concentration, manipulation of alveolar ventilation, manipulation of your arterial blood supply. Only thing we cannot manipulate here is the brain partial pressure. But to achieve the brain partial pressure, we can do jugglery or changes in these three components or variables that can be modulated. So if you understand all this concept is given very simply in this particular flow chart. Vaporizer, we set the concentration. It goes through the anesthesia circuit to the patient's airways, which is the inspiratory concentration, and it ultimately reaches the alveolar, which becomes the alveolar concentration. From the alveoli, it is taken up by the blood, pulmonary circulation, arterial blood, then it becomes arterial concentration, and it reaches the body organs where it is a vessel-rich group, fat, muscle, and vessel-poor group is there. Among the vessel-rich group, you have the brain, which is the main site or target action. And once you achieve a equilibrium of partial pressure of this brain tissue with the alveoli, which is dependent on these factors, you will go to the state of anesthesia. Is it clear?
Yes, sir.
Okay. Now, what is partial pressure of a gas and how is it expressed? This is going to be a small question and answer session. So we'll have to define or explain what is the partial pressure of the gas and how is it expressed.
Expressed in millimeter of mercury, sir.
Meters of mercury. What is the definition of partial pressure of a gas? All of you would have heard about Dalton's law of partial pressure, isn't it?
Yes, sir.
School physiology, school physics rather, not physiology, school physics. So the definition is pressure exerted by an individual gas in a mixture is known as partial pressure. Okay, pressure exerted by an individual gas in a mixture, because your atmospheric air is a mixture of nitrogen, oxygen, and small other gases. Similarly, inhaled anesthetic agents also will mix in this air only and go along with that, isn't it? So that becomes a mixture. So whatever the pressure exerted by the individual gas is a mixture is called the partial pressure. It is usually reported as percentage or fraction of the delivered gas mixture. For example, where it will be 1 atmospheric pressure. We always, even though we deliver gases and the vapors from the anesthesia machine, ultimately it is delivered at atmospheric pressure. Even though you have a cylinder pressure of 2000 psi for oxygen, it is reduced at various levels. At the pressure regulator level, it is reduced to 14 to 15 millimeters, and then at the flow meter level, it is about 10 to 12 millimeters, and ultimately all the gases are delivered at the common gas outlet at atmospheric pressure. Okay, so that is the criteria. So out of this, just as we discussed first in the discussion, that oxygen will occupy or give a pressure of 157 millimeters of mercury because it is 20% or 21% in the total mixture. Similarly, the inhaled anesthetic, depending upon the concentration that you give, they will exert a partial pressure among this or in the mixture of this alveolar gas or the total 760 millimeters of the pressure that is exerted or inhaled. So what factors govern the alveolar concentration of an inhaled agent? Once the gas is delivered or the vapor is delivered by the anesthesia machine, it has to reach ultimately the alveoli. So what factors govern the alveolar concentration of inhaled agents? Supposing you give a higher percentage, 3% or 4% sevoflurane, and another person you give 1% sevoflurane, which patient will achieve the alveolar concentration or partial pressure faster?
More percentage. Higher
More percentage. Okay. And suppose one patient that has a minute ventilation of 8 liters, another patient is made to breathe hurriedly and his minute ventilation is increased by 12.
Minute ventilation more.
So inspired concentration is determined by fresh gas flow, breathing circuit volume, absorption of agent by the components of the breathing circuit. Okay, these are the 3 things which determine the inspired concentration. Fresh gas flow, that is how much liters of gases you are giving totally. Breathing circuit volume, absorption of the agent by the components of the breathing circuit. Normally, what is the breathing circuit volume when you are using a closed circuit or a McGill circuit? Which are all the components which will contribute to the volume of the breathing circuit? Every day you are using the breathing circuit for giving anesthesia, isn't it? So what are all the components of the breathing circuit? The simplest, easiest component to say is the
Mask, corrugated
mask.
tubings.
Okay, mask. Corrugated tubing is there, isn't it? Long corrugated tubes are there. Reservoir bag is there, isn't it? The connectors are there. So
HME
these are the
filter.
things which are contributing to the total volume of the breathing circuit. Okay. So these 3 things are the inspired concentration. The second is the alveolar ventilation, and third is the functional residual capacity of the patient. So in which are all the patients the functional residual capacity will be reduced?
In obese
Obese,
patient,
pregnant,
Obesity,
pediatrics, Pediatrics,
I
pregnant
have
patients.
already told in several classes the mnemonics to remember where FRC will be reduced. Can anyone remember that and tell me? PANGOS, Pangos. Remember that?
Sir.
Yes,
I
sir.
told that in several classes. PANGOS, Pangos. P for pregnancy. A for ascites. N for neonate.
Neonates.
P for general anesthesia. O for obesity. S for surgery, especially upper abdominal surgery. Okay. In these 6 conditions, FRC will be reduced. If FRC is reduced, will the patient be anesthetized faster or it will take time?
Faster, sir.
Faster.
Faster.
Because FRC will be diluting your anesthetic agent that you are delivering, isn't it? So if you have a larger FRC, it is going to take a longer time to achieve the alveolar partial pressure. Whereas if you have a lesser residual capacity, that will cause lesser dilution and alveolar partial pressure achievement will be much more faster. That is why these categories of patients will go under faster if you give inhalation agents and induce them by inhalation technique. Pregnant patients, obese patients, and neonatal patients, these patients will go under faster because they have lesser FRC. So the 3 components or factors which govern the alveolar concentration. One is inspired concentration, the second is alveolar ventilation, third is residual capacity, FRC. Now this alveolar ventilation, if a patient has a larger ventilation, will he be anesthetized faster or will he be anesthetized slowly? I told you the unit ventilation of one patient is 8 liters, another patient is 12 liters. Which patient will become anesthetized faster?
More minute.
12 liters.
12 liters. You mean to say 12 liters will be induced faster?
Hyperventilate.
Wash it.
Hyperventilate panna.
He will be taking up the agent much faster. So he will not allow the alveolar ventilation to partial pressure to become equal to inspired concentration. Okay. So lesser the ventilation, the achievement of alveolar partial pressure will be faster because the drug elimination from the alveoli to the blood is little slower. So the first step, as I told you, we have to achieve an equilibrium between the inspired concentration and the alveolar partial pressure. Okay. So for that, when the drug is taken up much more rapidly by a faster ventilation or a faster cardiac output also, which we'll be seeing, the patient will take longer time to achieve equilibrium between the inspired concentration and the alveolar concentration, partial pressure. Okay. So lesser the ventilation, easier to achieve the alveolar equilibrium or partial pressure equilibrium compared to a patient who has a larger ventilation. Okay. So that is the simple thing that you have to understand. Whereas FRC should be lower to achieve a faster equilibrium and not a larger FRC. So these are the first 3 factors. Then what factors determine the uptake of agent from the lung? So here it is from the machine to the alveoli. The next step is from the alveoli uptake of the agent from the lung into the system. Is this question clear to you?
Yes, sir.
Yes,
It is less
Just
fat.
now from the
Alveolar
machine it has
concentration.
to reach the alveoli. Now it has reached the alveoli. The lung means it has reached the alveoli. From the alveoli, where should it go?
Blood.
Into the blood.
Blood.
What factors should govern here from the uptake from the lung into the blood?
Alveolar
Yeah.
concentration and
Solubility here.
blood gas
The first
partition.
factor is the solubility. Blood gas partition coefficient of the agent. Okay. The second is pulmonary blood flow or output. Unless you have a good output or good pulmonary flow, there will not be enough blood to take up the oxygen. Third is alveolar venous partial pressure gradient of the agent. Okay, so this is the three, just like you have three factors here for achieving alveolar partial pressure. These are the three factors to determine the uptake from the alveoli into the blood: solubility of the agent, pulmonary blood flow, alveolar to venous partial pressure gradient. And venous partial pressure gradient will be initially zero because there is no inhaled agent in our body. So the initial few breaths will be a drastic gradient, high, very, very high alveolar partial pressure to zero venous partial pressure. But once the drug goes through several circulations, part of the gases will be coming back, and there will be very minimal gases present in the venous blood also. So that is determined by this formula. What is this symbol?
Sigma.
Lambda.
Lambda. This is a Greek symbol, alphabet, which is called lambda, blood gas partition coefficient.
Cardiac
Q is the blood flow,
Cardiac output.
and partial pressure or difference between the alveoli and venous pressure. If all these are multiplied and divided by the barometric pressure, you will get the factors which are responsible for the uptake of the inhaled agent from the lung into the blood. So the first step is to achieve equilibrium between the inspired concentration and the alveolar concentration. Second step is to deliver the alveolar inhaled agent into the blood using these three. Now, what is the effect of alveolar ventilation on alveolar partial pressure of the agent that we have already asked? So increased alveolar ventilation helps to achieve a faster increase in the alveolar pressure as it quickly replaces the agent taken up by the blood through the pulmonary vessels. But what will happen if the solubility is very low? It will achieve a faster equilibrium. But if the solubility is very high, it will not allow the ventilation to get the alveolar partial pressure equal to the inspired partial pressure. So what is the influence of functional residual capacity on alveolar partial pressure? So FRC is large, it will dilute the inspired concentration of the inhaled agent and reduce the partial pressure and slow down the induction. For example, patients in COPD who have the air trapping and their volume FRC becomes more, they will have a slower induction. On the contrary, if FRC is reduced, it will not dilute, so maintain partial pressure and help faster induction. Example of these patients are pregnancy, neonate, and obesity. So is it clear now?
Yes, sir.
Yes, sir.
Okay. Now comes another important concept which you have to understand is this time constant. What is time constant? What is its relationship to the fresh gas flow and the lungs? First of all, what is time constant? One says that.
So it's a time taken for the time constant is volume by flow, sir. That is the time required for the flow to the container.
To fill up a container. Okay, the time required to fill up a container is called the time constant. Okay, so the time constant is nothing but time required for a flow through a container to equal the capacity of the container. That is the simple definition of time constant. Now the symbol of time constant is tau, the 19th letter of Greek alphabet, which can be written as a capital T or smaller lowercase t. So the calculation is volume by flow. So what is the total volume? For example, if your lung has got a volume of say 10 liters and you have a flow of 2 liters per minute or 3 liters, 5 liters per minute, how much time will you take to fill up that entire lung?
2 minutes.
10 liters is the capacity, 5 liters is the fresh gas flow. So 2 minutes it will take. Then 10 divided by 5. Okay? So this is an important concept. For lungs, it is the FRC versus the volume of alveoli. Okay? So that is how the ventilator, alveolar ventilation and FRC is the formula for the lungs. So for anesthesia circuit, it is the circuit of the capacity of the cap circuit divided by the fresh gas flow. So just now I asked you what are all the things contributing to the capacity of your breathing circuit, and what is the normal volume of your breathing circuit. If you are using the regular corrugated, what is the length of a corrugated tube that you use in your anesthesia machine? What is the standard that should be?
60 meters, sir.
Huh?
100 meters.
1 meter, yes, 100 centimeters, 100 not meters, 100 centimeters or 1 meter, okay? It is supposed to be 1 meter capacity, so that or your arm strength, that is the normal thing that you have to, so that you can reach the reservoir bag easily, okay? So when you calculate that, roughly it will be about 5 to 6 liters will be the capacity of your breathing circuit. And this, supposing you are inducing with the equal volume, say 5 liters or 3 liters of oxygen and 3 liters of nitrous oxide, and your capacity of your breathing circuit is 6 liters, the time constant for that is such a simple mathematics, none of you are answering. Capacity is 6 liters, fresh gas flow is 6 liters. What is the time constant?
1 minute.
1 minute. Why so much hesitation? Okay. So the fast, if you want to achieve a faster time constant, that is to fill up the capacity, you should be delivering the fresh gas flow at a volume that is equal to the capacity of the circuit. Then only you can fill up that faster. Why this filling up is important? When you give an inhalation agent, and when you want to fill up the breathing circuit by using the time constant concept, what is the importance of that? Why do you want to do that? Before starting anesthesia, what the circuit, what do they contain?
Room air, sir.
Room air. That has to be removed and it has to be filled up with the anesthetic gases that you are giving, oxygen, nitrous oxide, and your inhalation agent, or oxygen, air, and inhalation agent, whatever you are using. It is just like priming your cardiopulmonary bypass circuit. Okay, the same way you have to remove all the air or make the patient inhale all the air and then fill up that whole circuit with the agents that you want to deliver and achieve the partial pressure in the alveoli at a faster time. Okay, so that is the importance of this time constant. So how does the concentration in the breathing circuit rise? If you want to increase the concentration of the anesthetic agent in the breathing circuit, what are all the things that you can do?
Set dial concentration of inbuilt anesthetic.
Expired?
Set dial
Increase
concentration of
the dial concentration.
Higher dial concentration, then will they are keeping the higher concentration of the dial alone is enough, which has to be carried, you know.
Increase
It-
fresh
it is
oxygen and
not just
nitrous
like a-
oxide.
you have to give a fresh gas flow. Okay. So it is reached by the first order kinetics. The rate of drug removal is not fixed amount, but rather a percentage of the remaining drug in the body. So the inspired concentration will be FFGO 1 minus ETT. What is this FGO mean?
Fresh gas flow.
Fresh gas at the outlet. Okay? FGO is fresh gas at the outlet of the machine. So this formula has to be used where it is inspired concentration, fresh gas concentration at gas outlet, time and the time constant. So if you use this formula, then you will be able to decide what concentration you will be able to deliver to the patient. So what is the significance of time constant in inhaled anesthetic use? Why do you have to break your head about this inhaled concentration? As I told you, your circuit capacity is 6 liters. If you use 6 liters, you will be achieving the time constant by filling up the entire circuit in 1 minute. On the contrary, you start with 2 liters, 1 liter of oxygen, 1 liter of nitrous, or 1 liter of oxygen, 1 liter of air, and try to fill it up. How many minutes will it take?
4 minutes, sir.
5 minutes.
6 by 2. Total volume press gas is 2. Capacity is 6.
3 minutes.
3 minutes, sir.
Okay? So you can achieve a faster induction by a lower time constant indicates a quicker response time, meaning that anesthetic concentration in the circuit will change more rapidly. And a higher response time constant is a slower response or a slower achievement of the anesthetic concentration. So whenever you want to induce, this is applicable mainly in pediatric anesthesia, where you do inhalation induction pediatric patients. So if you want to induce the child faster, who is already will be in a very distressed state, crying and having separation anxiety and all these things, if you are not adequately pre-medicated or if you are not allowing the mother or somebody to accompany the child, and you want to induce the child faster without any further delay, then you have to use a higher concentration to fill up the circuit much faster and make the patient inhale a higher concentration so that the alveolar partial pressure will become equal to the inspired partial pressure much faster. So the induction will be much more faster if you know these particular points so that you can induce. That is why when you do inhalation induction in pediatric patients, what is the concentration of sevoflurane you have supposed to start with?
8 first.
8 liters along with the fresh gas flow of at least 6 to 8 liters. And once you do that, within no time the child will become under and you can then gradually reduce it. Okay, so that is the importance of this time constant. So how can this change be achieved to get a quicker response? One is increasing the fresh gas flow or by reducing the volume of the circuit. So you remove the unnecessary components like extra connectors or reduce the volume of the tubing, then you will be able to achieve a faster response time and induce the patient much more faster. Then in which inhaled anesthetic technique, time constant has a significance. One I have already told you is the induction in pediatric patients. Any other type of inhalation induction anesthesia, this time constant will become more significant.
Nitrous oxide.
Huh? What is the current latest concept in the usage of inhaled anesthetic agents? Do you use a very high flow or you reduce the flow and use a
Low flow.
so it becomes very important in low flow anesthesia, because in low flow anesthesia, if you have read the topic and if you remember, during induction we always use a higher flow to achieve a higher quicker response by improving the time constant. Then once you achieve the desired level of anesthesia, to maintain you go to the metabolic flow and then the minimal flow and all those things. Okay, so from this point of view of low flow anesthesia, for faster induction you require to know this about this time constant. And another indication is also the pediatric induction, where you use a higher flow rate, and the pediatric circuit, especially the Jackson-Lee circuit, they have a lesser volume. So the time constant can be achieved with a higher flow rate and the faster induction can be achieved in children. So these are the two important indications for knowing about the time constant in this particular uptake discussion. Now, next comes so we have managed to give adequate inspired concentration. We have achieved the needed partial pressure at the alveoli. So once that equilibrium has come, then the gas has to pass from the alveoli into the bloodstream. And that is where the solubility coefficient has come in. Now, what is solubility or partition coefficient? What is its importance? We have already told that. Now, can you just try to answer that? How do you define this solubility or partition coefficient?
The solubility of the inhaled anesthetic in blood and tissues.
In two different phases. Okay, so the partition coefficient is the ratio of the amount of substance present in one phase compared to the other phase, and the two phases being equal in volume and in equilibrium. So some of the definitions you have to by heart if you can't remember that, because when you are asked a question like this in the theory examination, these points have to be written correctly. So the partition coefficient is the ratio of the amount of a substance present in one phase compared to the substance in the other phase, and the two phases being equal in volume and in equilibrium. So it exhibits the solubility of a substance in different medium or phases. So higher the solubility, more time to achieve the balance or equilibrium between the alveolar and inspired concentration, slower the induction. Example is halothane or ether. All these things are supposed to have a higher solubility. Whereas lower solubility, faster achievement of the equilibrium between alveoli and the inspired concentration, faster induction, and examples are nitrous oxide and desflurane. Okay, so this is the importance of this particular terminology, which this definition you have to definitely remember. So it is very easy to remember. It is the ratio of the substance in two phases between blood and gas here, or blood and tissue at the other level when it goes to the brain. So isoflurane at 1.4 equilibrium, the concentration of blood is 1/4 times its concentration in the alveolar phase. Okay, so when you say the blood gas solubility coefficient of isoflurane is 1.4, somebody said 0.6, it is not 0.6, it is 1.4. So at that equilibrium, the concentration in blood is 1.4 times more than the concentration in the alveoli. Or each ml of blood will hold 1.4 times more isoflurane compared to 1 ml of alveolar gas. So do not indicate partial pressure in blood is 1.4 times in the alveoli. It is the molecules that are present here. So if you see this picture, blood has 14 molecules of isoflurane per ml, whereas the alveolar gas has got 10 molecules per ml. So the net diffusion when partial pressures are equal will be this balancing here. So mention the various partition coefficient of commonly used agents. This may be asked in the examination. So nitrous oxide has a blood gas coefficient of 0.47, halothane 2.5, isoflurane 1.4, desflurane 0.45, and sevoflurane 0.6. This is the very important value that you should remember at the alveolar blood level. Whereas the brain blood, which is given the next one, is the where the blood has to go and deliver the inhaled agents to the vessel-rich group organ like brain. So once you achieve a equilibrium between the alveolar partial pressure and the brain partial pressure, your anesthetic state will be complete and you will be fully induced. So that value for nitrous oxide is 1.1, for halothane 1.9, for isoflurane 1.6, desflurane 1.3, CO 1.7. So if you see, these values are more or less same because the brain is able to take up these gases at a more or less the same rate because of what is the thing that makes the gases get into the brain easily? What is brain made up of? What the cells of the brain? What layer they are all having?
Blood-brain barrier.
Blood-brain barrier. What is the content mainly in the brain? இதெல்லாம் ரொம்ப கொழுப்பு தானே தலையில. Lipid layers, isn't it? The lipid layer is more dominant in the brain. That is why it is able to take it up much more faster, and there is a rich blood supply also. Okay, so these two values at least you must remember that which are important for the uptake at the lung level and the delivery at the brain level. So these are the values which you remember. Sometimes they ask you in the Viva to mention these values. Now, what is the role of cardiac output in the uptake of inhaled agents? Supposing you have a normal cardiac output, a low cardiac output, and a high cardiac output. In these three states, how will it affect the uptake of the alveoli? I mean, the gases from the alveoli.
Increased cardiac output will take increased time constant, sir. So
Increased cardiac output will, is it a relationship, time constant?
time constant will increase, sir.
I think you are.
Increased cardiac
Time
output
constant is
faster
the
uptake.
time taken for the flow to fill up the capacity of a container or an organ. Now in blood, where is the question of time constant? You take an alveoli, it is like a balloon. It has to be filled up. It is a container which has to be filled up. So how much time you will take to fill up and expand that alveoli is the time constant. In blood, where is the question of using time constant there?
Tissue
It is the
perfusion.
solubility, isn't it?
Yes, sir.
So
Low
the blood flow, supposing you have a very high blood flow and the drug is taken up faster or slower?
Faster, sir.
Increased uptake. So once the drug is constantly removed from the alveoli into the blood, will it be able to achieve an equilibrium between the inspired concentration and alveolar concentration?
No, sir.
No. So you get a slower equilibrium of alveoli to inspired concentration. On the contrary, if the blood flow is slower, cardiac output is low. For example, a patient in shock, a polytrauma patient coming in shock. If you do an inhalation, and will he go under faster or will he take a longer time?
Longer time. only.
Faster, sir.
Will go faster because the blood flow is slow. The uptake of the gases from the alveoli will be slow. So you can achieve the equilibrium between the alveoli and inspired concentration much more faster. Okay, but ultimate reaching of this agent to the brain is going to take a little more time. But the alveolar equilibrium and the FI equilibrium will be achieved much more faster. So induction at the alveolar level or achievement of partial pressure equilibrium at the alveolar level will be much faster if the cardiac output is a little low. Whereas if the cardiac output is normal or high, it will be constantly taking up the gases or the inhaled agent from the alveoli. So to achieve this first step of equilibrium between the alveoli and the inspired concentration, it will take a little longer time. The factor which determines the alveolar to venous partial pressure, that is the next thing.
To the tissues, sir.
This is determined by the tissue uptake at the blood. Okay, so the tissue partition coefficient and the blood flow to the tissue is important. So that is the correct answer what we have to say. So if the tissues are avidly taking the inhaled agent, the blood returning to the alveoli will be having lesser amount of inhaled agent. So the transfer will be much more faster. Okay. So the tissue partition coefficient determines the alveolar venous partial pressure coefficient. Okay. And how are the tissues which take up the inhaled agent classified? And give examples. We have already seen that you have vessel rich group, you have a muscle group, you have a fat group, and you have vessel poor group like cortical bone or very insignificant uptake from these things. So some books don't mention this at all, but these three groups are commonly given. And this is the one which will take up the inhaled agent at a much more faster level. And the brain is the most important target where we have to achieve the equilibrium of partial pressure between the alveoli and the brain tissue. Now, what is the importance of these other tissues which take up the inhaled agents? They also take up the agent, even though they cannot produce any unconsciousness or clinical anesthesia. Your muscle and fat, they also take up the inhalation agent and they release it slowly. So what is the significance of that? Answer all.
Increase ventilation.
So will they be holding on the inhalation agent all through, even if when you discontinue your anesthesia? See, you are giving anesthesia with an inhalation agent for say 3 hours or 4 hours, and all the time the vessel-rich group drugs are taking the inhalation agent. They have achieved the saturation. They have maintaining the partial pressure. These two other groups also have taken up, but they cannot have any effect on the brain and they cannot produce any state of anesthesia, but they contain some amount of the inhalation agent. So when you discontinue, how does the patient recover?
A delayed recovery, sir. Prolonged.
They recover because the brain first releases all the inhaled agent it has taken up into the blood. That comes to the lung. The patient exhales out that agent because there is no agent now supplied. He exhales out. So the brain concentration on partial pressure comes back to normal, and the alveolar partial pressure also becomes low. And the neuronal activity is restored or the conscious level is restored, the patient comes out. But these other groups also which have taken up the inhalation agent, they will also release that slowly. So some amount of inhaled anesthetic agent will be present in the blood all the time, even though they cannot produce any anesthesia because they cannot achieve the partial pressure that is required to produce the anesthesia. But this may produce what is called the lingering effect or the hangover effect. Slowly they will be releasing. That is why we are going to discuss about what is called MAC awake. MAC awake. What does that MAC stand for?
Minimum alveolar
Minimal alveolar concentration awake. So when the patient is awake, there is still some amount of inhalation anesthetic agent present in the blood and alveoli that is released from these tissues which have taken up that, and they have not utilized this for any purpose. Okay, so that is the importance of this supply or the distribution of the inhaled agent to non-target areas like brain. Okay, so muscle group and fat group, they are important for releasing the inhaled agent slowly after discontinuation of the anesthetic agent, and they are responsible for producing a condition called MAC awake, where patient will still have some amount of concentration of the anesthetic agent in the body and the alveoli, but still he may be responding to your verbal commands. Okay, so what is the effect of ventilation on the uptake? Increased ventilation, faster FAFI, faster induction. Example, halothane in sevoflurane. Is the uptake of nitrous oxide influenced by ventilation? If you are going to use halothane or sevoflurane, definitely increasing the ventilation will increase the uptake and the patient much faster. But supposing instead of giving 6 liters of nitrous oxide, you give 10 liters of nitrous oxide. Will it have any effect?
It will.
Yes, sir.
Nitrous oxide is poorly soluble and has a blood gas solubility coefficient of 0.5. Increasing the minute ventilation has negligible effects on its uptake. Okay, so you will be reaching the alveolar partial pressure much faster because it is poorly soluble. So, however much you try to increase the ventilation, it will not help in faster induction. Whereas in the case of halothane and sevoflurane, which are more soluble in blood, a faster increase in ventilation will definitely help in achieving a faster FAFI. Okay. What is the concentration effect? To which agent this is applied and why?
Nitrous
Another
oxide.
important confusing gray area for many students. So this we will try to discuss a little detail. What is the concentration effect? And to which agent this is applicable and why is it applicable to that agent?
Nitrous oxide, sir.
It is applicable only to nitrous oxide. Why? Right. So increased inspired concentration, increase the alveolar concentration, increase the rate of FIF. This is the basic thing normally we have to know. So if we increase the inspired concentration of an agent, we increase the alveolar concentration and achieve the equilibrium between the alveoli and the inspired concentration. It is mainly applicable to nitrous oxide because higher volumes of nitrous oxide can be administered safely. Do we normally apply 3:6 or 2:4? We give almost twice the amount of oxygen when we use nitrous oxide. But we don't give such high concentrations or high volumes of other inhalation agents. So the concentration effect is only applicable to nitrous oxide because we can give higher volumes. Now, the speed of uptake based on what factors? Now we can see here nitrous oxide has a lesser solubility, so faster induction, whereas halothane has a more solubility, blood gas partition coefficient, slow, it dissolves and goes for a slower induction. Distribution to various tissues, what we have seen is through the fresh gas flow coming to the breathing circuit, coming into the alveoli, achieve the alveolar partial pressure equilibrium. And once it goes to the arterial side, it goes to vessel-rich group, muscle, fat, etc. And then when it comes to partial venous pressure, it should be lower because it has been taken up by these tissues. And this gradient again will help in the movement of the inhaled anesthetic agent from the alveoli into the blood. So this diagram, if you remember, it is easy to remember the uptake and distribution part of it. This shows the uptake at the lung level based on the blood gas partition coefficient. Now, some people discuss about Mapleson water analog for the distribution of the agents to their various groups, and this is more of a theoretical thing to say how fast it is going to fill up the various tissues to achieve the equilibrium there. So just to know this is enough. More than that, this is not going to be of much help in understanding, but you can say that the vessel-rich group, which has a smaller volume of total tissues we have, but they have a higher blood supply represented by a larger size pipe. And the next higher portion of the tissues is muscle, and the maximum portion is by the fat. And the fat have the least amount of blood supply represented by a very thin pipe that is supplying. And you have the muscle which has an intermediate size pipe which is supplying. And the supply of the inhaled agents to the brain, which is the vessel-rich group organ, that is the main thing which we are worried about and concentrate on to achieve the equilibrium to attain the state of anesthesia that we require. Okay. Now the concentration effect. How to describe the concentration effect? What are the components of concentration effect? This is applicable again, as I told you in the earlier slide, mainly to nitrous oxide. It is not applicable to sevoflurane or your halothane or your desflurane. So in what way nitrous oxide is able to have a unique property of this concentration effect? We have studied that, you know, there are two components of this concentration effect. What are the two components?
Inspired concentration and double.
Inspired concentration effect has got two components. One is called the concentrating effect. The other is augmented pulmonary flow. These are the two components. Okay. There's a two parts. One is called concentrating effect. Other is augmented inflow effect. Okay. Now we'll see what is that. Concentrating effect is defined as a higher inspired concentration resulting in a disproportionate increase in the concentration. Okay. The concentrating effect is defined as a higher inspired concentration resulting in a disproportionate increase in the concentration. I will explain to you this point by the diagram which is going to come. And augmented inflow effect is where more gas is drawn into the lungs to replace volume taken up which augments the alveolar partial pressure and helps to increase the FAFI. That is, ultimately we have to achieve an equilibrium between the inspired partial pressure and the alveolar partial pressure. This is the point I have been insisting again and again from the beginning. So if you have a augmented flow, once the agent is taken up the blood, it is immediately replaced by the flow. So this is a second part of the concentration effect. And to understand the concentrating effect, this is the first example. But if you logically think about it, these examples given in the books, they all describe only about a single breath. But what is happening is a continuous process. We don't take a breath, wait for that to become equilibriate and everything, and then take up the next breath like that. So it is a calculation made to find out how fast the induction is happening. So that's the point that you have to understand. So it will not take that much of gap to between. Here the picture shows the first breath and second breath and all these things, but all these things are taking place in a rapid sequence. So, but that has been split to understand how this concentration effect is going on. So with that particular explanation, let me tell you, the first breath if you take, you have 70% of the total volume made up of nitrous oxide, and 28% of volume is by oxygen, and there is a 2% of your inhalation anesthetic agent, say any sevoflurane or desflurane, whatever you want to take. So it makes up a total volume of 900, 70 plus 28, 98 plus 200. Okay. So the inspired concentration of your inhalation agent here is 2 parts out of this 100, so it becomes a 2%. Okay. So the inhalation agent delivered the first breath during one breath is the 2%. Now, because nitrous oxide is taken up rapidly because of its less soluble, it is taken up rapidly. So let us say that 50% of the nitrous oxide has been taken out by the blood. Then what happens? The 70 volume becomes 35, and it is presuming that no oxygen is taken up and no inhalation agent is taken up because they are all little slow in going into the blood. Okay, so the rapidity with which the nitrous oxide goes into the blood produces a state where the other two agents are still remaining the same, and the total volume now gets reduced from this 100% into 28 plus 35 plus 2. Okay, so that means 43 plus 20, 63, 65. So the total volume gets reduced to 65 ml or 65%. And out of this, you have again the 2% concentration because it is not yet taken up by the blood. So here what happens? What you initially supplied as 100%, 2% because of the 100 volume, now gets concentrated to 3.1%. Okay, because of the rapid uptake of the nitrous oxide, the total volume gets decreased, and these two have not been still crossed over to the blood. And that is the reason why this percentage of your inhaled agent appears to be increased because of the reduction in the total volume. Is it clear to you now?
Yes, sir.
Yeah. Now you take, the patient takes the second breath. So the first breath here, it is the inhalation and filling up of the alveoli, from where 50% nitrous oxide is taken up. The rest of the alveolar volume is described here. And from here, the second breath comes. So at that time, again, some more gases of the same composition come here. So that comes and fills up the whole thing. And that will take up the volume to this particular concentration because it is replacing part of the nitrous oxide, giving some more oxygen, some more of the volatile agent. Everything is getting increased, and the total volume is getting restored to the original level. At that time, what happens? The concentration of your volatile agent becomes 2.7. So from 2%, which you are giving initially, because of the rapid distribution or uptake by the blood, the volume getting decreased, it becomes 3.1. And when the next breath comes and again dilutes the gases, it goes down to 2.7. So this is what is called the concentrating effect. It is concentrating the gases other than the nitrous oxide because of the rapid uptake of nitrous oxide. Is it very clear now, or do we have to explain it again?
Clear, sir.
Clear. Okay. So what is the second gas effect? Now, it is nothing but an offshoot of this concentration effect. This is second gas effect. What is the meaning of second gas effect?
Another gas. First gas, nitrous oxide is oxygen by oxygen. So
the concentration effect of one gas upon another gas is known as second gas effect. Now, in this explanation, I have told you that because nitrous oxide is taken up rapidly, the concentration of your volatile seems to be increasing from 2% to 3.1 and 2.7. And when this percentage seems to be increasing, will it be able to rapidly go into the blood or slowly go?
increasing rapidly.
It will rapidly go. So that is how the nitrous oxide helps in the uptake of another agent, like especially halothane or sevoflurane, whatever agent which is more soluble, which will rather take a long time to enter the blood. It is facilitated by the rapid uptake and by the increase in the concentration that is produced because of the removal of nitrous oxide from the alveoli. This concentration becomes more, and that facilitates to set up a gradient and help in the absorption of the second agent into the blood. So this property, how does it happen? Nitrous oxide has a property due to its concentrating effect. As a higher concentration of nitrous oxide is taken up from the alveoli, the remaining gas gets concentrated. This is what I told you, which enables a rapid uptake of the second gas, also second agent. So why nitrous oxide is called a carrier gas? Again, the definition is it is called as a carrier gas because its rapid uptake can enhance the uptake of other anesthetic agents, leading to more rapid induction of anesthesia. Okay, so this is the whole concept of concentration effect and the second gas effect, which are interconnected to each other, which is applicable only to nitrous oxide, and which is a very useful practical tip that if you give more nitrous oxide along with your inhalation anesthetic agent, the induction will be much more faster rather than giving oxygen and air composition, which is normally used nowadays. So you can use nitrous oxide at least for the advantage of a rapid induction by giving a air concentration of nitrous oxide along with the volatile anesthetic agent. So even a lower percentage of say like 1% or 2% will get augmented because of the rapid uptake and make a more concentrated percentage in the alveoli, which will help in the diffusion and uptake of the highly soluble agent much more rapidly compared to the agent given alone. Okay, so that is the concentration effect and the second gas effect, which is a common question examiners ask you. I hope it's quite clear now. Shall
Yes,
we
sir.
move on?
Yes, sir.
Yes.
So what factors affect the arterial concentration of the inhaled agent? That is, we know that from alveoli it has to go into the blood, and the arterial concentration is the one which has to deliver the whole thing to the tissues. So what factors affect the arterial concentration? It is the alveolar dead space, venous admixture, heterogeneous alveolar gas distribution, and leaky mismatch. So if all these things which determine the partial pressure difference between the alveoli and the venous blood, then that will affect the total arterial concentration. So alveolar dead space, if it is more, again it is going to be a wasted ventilation, venous admixture. Just like the factors which cause the shunt and venous admixture in oxygen uptake, the same thing you can remember, which will also affect the uptake of the inhaled agent into the blood circulation. Enumerate the factors that increase or decrease the equilibrium of alveolar to inhaled air concentration.
Blood
So you
soluble.
can divide it into respiratory part and circulatory part. So this is nothing but a compilation of what we have seen so far. How you can achieve the equilibrium faster using ventilation and distribution, or ventilation and circulation. So here, factors which increase the achievement of faster alveolar to inspired concentration are if the drug is not very soluble, like nitrous oxide and desflurane. If you have a low cardiac output, blood stays longer, so it will not. It will allow a faster rise in the alveolar. High minute ventilation will also replace the taken up gases faster, and it will achieve the FA-FI ratio much faster, and high pulmonary artery to venous partial pressure difference. These are the four factors which will increase the achievement of faster FA-FI ratio. If the drug is highly soluble, it will take a longer time. High cardiac output again will remove the drug. Low minute ventilation will also take longer time to achieve, and low pulmonary artery to venous pressure. So opposite of all these things will decrease the FA-FiO2. So this 4 points, if you remember, it's much more easier to manipulate your induction time. So you use a drug which has a low solubility, you give high minute ventilation, and these two things, if they are there inherently in the patient, that will achieve a faster FA-FI equilibrium. Then once the drug is distributed and reached the brain and it has achieved the alveolar brain partial pressure equalization, you maintain a state of anesthesia. But as the drug is being inhaled into the body, it starts undergoing some amount of elimination, and finally when you want to recover the patient, the drug has to be eliminated totally from the body. So what are all the modes by which the drug gets eliminated? Inhaled agents get eliminated from the body.
Lungs and
Lungs.
Mainly by lungs.
Lungs.
Most of them will be exhaled back without getting metabolized. But very, very low percentage can be metabolized in the liver also. So by lung depends on cardiac output, minute ventilation, and solubility. Again, these three points which are important for uptake. They are important for elimination also, because that has to be exhaled out, not metabolized. Okay. Second thing is distribution to tissues and minimal metabolism by liver enzymes. So the non-active sites where the drug has been taken up, like muscle and fat, they don't produce any unconsciousness anymore, but they slowly release that. But that the concentration in the blood released by them is so low that it cannot produce any effective anesthesia or unconsciousness. So that distribution also helps in elimination of the inhaled agent. And third, there is a very minimal elimination from the percutaneous. In those days when we used to use a lot of ether, when we go home after working in the theater, my children used to ask, are you coming straight from theater? Because my dress, everything used to smell of ether. So that percutaneous and visceral elimination, even though it is insignificant, the odor will be there. And another important thing which is commonly asked is, what is diffusion hypoxia? What is the other name for that? And what is its significance?
At the end of procedure, we are suddenly cutting nitrous oxide, sir. If
Very
it will,
good.
nitrous oxide will move the blood from enter fast in the alveoli, sir. So we have
Very
to
good.
keep oxygen before keep cutting the nitrous oxide, sir.
Very good. Any other effect? So all of you have to remember that nitrous oxide is taken up faster and also removed faster from the blood because of its low blood solubility. Okay. So it is taken up faster and removed faster. So as she rightly said, at the end of anesthesia, when we want to recover the patient, we first switch off the inhaled anesthetic agent vaporizer, whatever we are using, we close it. And then we try to cut out the nitrous oxide and give 100% oxygen. That is the way we usually recover the patient, isn't it? So at that time, what happens, because the nitrous oxide is such fast agent to come out also of the blood, it will come into the alveoli and dilute the oxygen that is present there and reduce the concentration of the oxygen. And that is called the diffusion hypoxia. And this may be very significant in patients who have already a low oxygen level in the pre-anesthetic state, like elderly, debilitated patient or patient with lung diseases who are all having a sustained hypoxemia. They may be affected more by the diffusion of nitrous oxide and reducing the concentration of available oxygen for the patient. Is there any other effect because of this large exodus or movement of nitrous oxide into the alveoli? Apart from the dilution of oxygen, can it dilute any other gas? What is the effect on carbon dioxide?
Combustion.
It will dilute the carbon dioxide also, which is required for stimulation of the respiration. Okay. So that may also reduce the respiratory effort. So direct dilution of oxygen will cause hypoxemia. Dilution of carbon dioxide will reduce the stimulation to the respiratory centers, and that may reduce the effect. Again, it will be affected in patients who are moribund and debilitated or elderly. So it is always safer to administer 100% oxygen till you patient is at least for 3 to 5 minutes after discontinuation of nitrous oxide. Okay. So when nitrous oxide is discontinued during the end of surgery, nitrous oxide rapidly diffuses out from the blood into the alveoli because of its low solubility. This dilutes oxygen and carbon dioxide in the alveoli. So dilution of oxygen causes hypoxia. Dilution of CO2 causes reduced respiratory drive and hypoventilation. It may aggravate or compound the hypoxemia. And this is also known as the Fink phenomena or third gas effect. The other name for this is a third gas effect. And this lasts at least 3 to 5 minutes. It will not cause any problem if cardiorespiratory reserve is adequate. It can be reduced or mitigated by giving 100% oxygen during recovery. Okay. So sometimes this is asked as a short note question. So remember all these points to answer that. Now comes another thing combined or important for inhalation anesthetic agent is called MAC. What is MAC? Definition of MAC.
Minimum alveolar concentrations.
It is the expansion, but how it is defined as? What you are saying is the expansion of the acronym.
The minimum alveolar concentration to inhibit the movement for surgical incision in 50% of the patient.
At 1 atmosphere.
At 1 atmosphere. That is very, very important. That is, so MAC is the inhaled anesthetic at 1 atmospheric pressure prevents response to surgical incision in 50% of the patients. So only 50% will be not moving. Other 50% may still move. So it is called, what is the other name for this?
Potency.
How should it be correct? How should it be correctly called? It should be called as MAC 50. Okay? Because there is another term called MAC 95 or ED 95. What does that MAC 95 mean?
In 95%
of the
It will prevent movement in 95% of the patients. Okay, so this is the original description by, you know, who is the person who gave the name MAC?
Mayor.
Eager, very good. So Edmund Eager was the person. So who introduced the concept of MAC? Why was it proposed? So Eager et al. 1965 introduced the concept of minimum alveolar concentration, and it since has been the standard for measuring the potency of a volatile anesthetic agent. So if the MAC number is low, what does it mean?
High potent.
It is very highly potent. If the MAC number is large, it is very
low potent.
potent. Okay, not important, but poorly potent. Okay. So what is Mayer-Overton theory? It is one of the oldest theories proposed for general anesthesia with inhalation agent. Okay. Mayer stated that all fat-soluble agents would be functioning as anesthetic due to their ability to cross the lipid bilayer membrane of the neurons. So this was the concept stated by them. They said any drug, any compound which is fat-soluble should have anesthetic property, but that was not true. Later it was disproved. So what are the various MAC used during inhalation anesthesia and what are their values? What are the various MAC awake?
MAC
intubation.
MAC intubation. Another one sympathetic autonomic.
MAC bar.
MAC bar. So there are MAC awake, MAC amnesia, and MAC bar, and also MAC for endotracheal intubation. Okay, so these are the 4 MAC naturally used, and MAC awake is 1/3 of the normal MAC value. MAC amnesia is 1/4 of the MAC value, and MAC bar is 1.5 times the MAC bar normal MAC value of any drug. Okay, so to suppress the autonomic response, you require a higher concentration. Whereas for amnesic purpose and for recovery purpose, you require only 1/3 and 1/4 of the MAC. And for intubation also, you require higher percentage because the laryngeal reflexes are quite strong. You require 1.3 to percentage of times of the MAC for children and 3 times the MAC for adults if you want to intubate them without a relaxant with the pure inhalation agent alone. What are the limitations of MAC? Why MAC is nowadays not given that much importance? See, as soon as you nowadays, pardon?
It is not a form of pure depth of anesthesia. Awareness.
Awareness, like that. See, why MAC was introduced? when it was the time when they were using inhalation agents as a sole agent for induction to maintenance and recovery for anesthesia. Okay, so before the intravenous induction agents, your relaxants and narcotics, they're all used. The so-called balanced anesthesia technique, which was introduced later, the initial anesthesia practice was with inhalation agents alone. No other intravenous agents were given. During that time, MAC had a very important significance. And only when you know how much MAC of drug you give, then only you can induce the patient faster and you can maintain that anesthetic plane throughout by using that MAC and all those things. But nowadays, we use inhalation anesthetic as a supplement. We don't depend on that for a total induction, maintenance, and recovery, like what it happened at the beginning of our anesthesia history, where anesthetic agents were the sole main inhalation anesthetic agents were the sole agents to use for the anesthesia. So once you start using the other agents, the MAC has got lesser significance. You can use a MAC amnesic dose or a MAC awake dose for just keeping the patient quiet at the end of surgery. You don't want to give a full MAC maintenance dose and make him deeper and delay the recovery because of your usage of other drugs. So MAC is not applicable when administering total intravenous anesthesia or when you use other intravenous agents for induction, and use MAC only for maintaining amnesia during maintenance phase, and then the MAC is not carry any major significance. And MAC cannot be used as a sole measure of anesthetic effect during balanced anesthesia where muscle relaxant narcotics are also used. Okay, so this MAC is more for a historical aspect, that it was present during the time when inhalation anesthetic agents were used as a sole anesthetic for induction and maintenance. That time it carried a lot of significance. But only thing that you have to remember this, by knowing the MAC value of the various inhalation anesthetic agents, you can find out which agent will be more potent and which agent will be less potent, and choose that particular drug according to the timing and the need of the surgery, and make a faster recovery of the patient at the end of the surgery, right? So what factors increase MAC and what factors have no effect on MAC? This is a common question they ask you in the Viva. So what factors can increase the MAC?
Chronic alcoholism.
Hyperthermia. Sir.
Hyperthermia.
COPD.
Chronic alcoholism. So MAC is increased in young patients, chronic alcohol abuse, hypernatremia, drug abuse like cocaine, acute amphetamine toxicity, etc. So these conditions require a higher MAC for induction and maintenance. Factors which cause no change in MAC are gender, does not differentiate between man and woman or child, and it does not cause much problem in hypothyroidism or hyperthyroidism. And hypercalcemia also, there is no alteration in MAC. Metabolic alkalosis does not have any effect, and duration of inhaled anesthetic use also does not cause any problem on the MAC. And the takeaway point about that is MAC is a standard measure of potency of volatile. It is inversely proportional to the potency, the MAC number, which is a unitless number again, just like your pH and your Reynolds number. This is also a unitless number, which is inversely proportional to the potency and mirrors the main partial pressure of gaseous reagents and acts on both the spinal cord and the brain, causing largely immobility, amnesia to acute memory and unconsciousness. And there is a 6% decrease in MAC per decade of age for all anesthetic, and the maximum value is attained at 6 months. MAC derivatives are MAC awake, MAC amnesia, MAC bar, MAC unawake. These two are more or less similar. MAC awake, some people say that it is the concentration at which patient will obey verbal commands. And this unawake means you can suppress the response to verbal commands. So it is better to remember this as a MAC awake, where patient with some amount of inhalation agent still present in the body will respond to your verbal calls. And MAC intubation, all the common things. And MAC awake value is lesser than the MAC of regular maintenance. Hypothyroid state will not have any effect on the MAC. And mutation in melanocortin 1 receptor gene is associated with increasing MAC values. And intravenous agents used in anesthesia potentiate or activate the GABA, and they decrease the requirement of MAC. So that is the reason why nowadays with the balanced anesthetic technique, we don't give that much importance to MAC that was given. And this is the last slide. If you remember this will give a complete idea. So from the machine, we deliver the inhaled anesthetic agents, which are carried through your breathing circuit and to the lung. So this is the FI that we want to inspire. And once it goes to the alveoli, you have to achieve a alveolar partial percentage. So the FI ratio, for which time constant is very, very important. And from there it is taken up by the blood. And for the nitrous oxide, you have to remember about the concentration effect and the second gas effect. And once the solubility coefficient of the blood determines how much is taken up, and it is delivered to the vessel-rich group, the brain, where the tissue blood coefficient determines the uptake at the brain level. And once all these things become equal, that is the alveolar concentration, the blood concentration, and the brain concentration, and all of them equilibrate, you achieve a state of anesthesia. And at the end of it, when it is eliminated, it is again eliminated by the lung, and the concentration gradually reverses back into the same path and comes out. And that is the end of uptake and distribution. Okay.
Yes, sir.
Yes, sir.
Any questions,
Yes, sir.
any doubts on that? Especially Muthupriya, who said it's very confusing. Have I ordered for the confusion, or have I succeeded in clearing the confusion?
Clearing the
Clearing,
sir.
Right. So shall we move on to the next topic?
Yes, sir.
Yes,
Yes, sir.
Vaporizers.
Yes, sir.
We will go to that also.